Social Studies of Medicine at McGill University. A fortuitous introduction several years ago gave rise to very rich intellectual collaborations that included an international workshop entitled Medicine Without Doctors, Disintermediation and Patient Agency, which no doubt crystallized my thinking and lit the fuse that led to this book. Thank you to Francine Dupuis, who worked by my side to build our healthcare and social services network over the past 7 years. You are the consummate clinical operations magician. Many of the ideas expressed in this book were thoroughly dissected through our numerous early morning meetings and late-night text messaging. You taught me more than you know. Eric Maldoff, thank you for years of rigorous discussion and debate about health systems, politics, and the vicissitudes of life. You gave freely of your valuable time, and our interactions were as close to Socratic learning or formal Talmudic exegesis that I could have ever hoped to experience. The rigor and logic of this book is perhaps proof that I was listening. To my mother, thank you for giving me a love of books that has remained with me throughout my life, and for continuing to be my biggest booster. Perhaps beginning to speak at the age of 5 was not a constraint after all. Finally, thank you to my wife Donna for all your love and support. Your incredible enthusiasm for reading and rereading each and every draft of the text was simply amazing to observe, and the pure joy you derived was awe-inspiring. Of course, I always suspected that your unstated design was to have the final say about any copy you were shown. Mission accomplished, my dear. Foreword. There is a long tradition in Western medicine in which patients matter most. For a long time, patients took a leading role in the medical encounter. In the 1700s, patients were the patrons of their doctors, paying them an annual fee to be looked after. In this setting, the doctor was economically dependent on his patients. Consultations took place in the patient's home. The patient set the agenda. The doctor interpreted and understood the disease based on the patient's personal experience. Symptoms like pain, swollen ankles, or weight loss determined the diagnosis. Tuberculosis, for example, was called consumption, describing the protracted decline the patient was going through. Such a diagnosis was highly individualized. It was about the individual patient's disease, taking into account their predisposition, their way of life, their specific environment, and their behavior. Therapy and prevention were equally individualized. Many therapeutic measures aimed at rebalancing the juices of the patient's body, the humors. This could happen through diet or through a change in one's life. It could also be achieved by bloodletting, which was applied to remediate an excess of a particular humor or evacuate corrupted humors. The patient's individuality was absolutely central for an effective treatment of his or her ailment. Moreover, patients were actively involved in setting up their treatment plan. They often knew a lot about medicine as part of their general education. Doctors and patients shared the same language about the body and its diseases. The idea of rebalancing the humors is an example of this common language. This kind of doctor-patient relationship was not universal, though. University-educated doctors were rare. They were expensive and only accessible to patients of a certain wealth and social standing. Most of the population consulted other healthcare providers out of a wide spectrum of practitioners that included barber surgeons, apothecaries, drug peddlers, bone setters, midwives, clerics, and all kinds of people with some expertise or training. The situation was very different in the hospital of the early 19th century, especially those in post-revolution Paris. Originally all-purpose welfare institutions, hospitals had become more and more medical over time. By around 1800, the majority of hospitals' inmates were in need of medical care. At that time, doctors had started to discover hospitals as places for training and research. Since hospitals were still primarily charitable institutions, their patients there were indigent.